Good morning and welcome to our monthly webcast. This is session number 103. I am Samir Mehta, your moderator. Being the first production of 2018, let me start by wishing you all a very happy new year. I need to make a few brief announcements regarding the online resources which are available to you on ccclivecases.org. All the cases which you see have been archived under the specific categories that should make it very easy for you to continue reviewing them. Also, all the slides which Dr. Sharma shows are there, so please take advantage of them. I have an update also on the Bifurcate app. It has been downloaded 2024 times already. It's available both on Google Play as well as on the App Store. Take advantage of it. We have also recently sent you a survey. If you are able to get back that to us, that will further help us. For the case today, it is almost similar to what we had last time, including the patient's age. 84-year-old, the difference being here the LV function is a little better, but to take you through a most complicating, challenging distal unprotected left main bifurcation stenting techniques, hopefully you will gain much from this. Sameen and Anu, good morning to you and a very happy new year to you.
All right,
Good morning.
happy new year to you and to all our viewers of the CCC live cases. And we know there is a little delay today because our usual room where we had done of the 102, 101 episode, one case we did in this room, room 3. Now we are back to our the second in 103 being done because that room is taking its towards its last breath. We are going to change, but will take few months.
Well,
But we'll have a new room probably in next 6 months, and time to time it may just go down, and that will exactly happen.
we have been updating the audience this morning regarding the delay, and hopefully it has not been too inconvenient to them.
Okay, so then we can just go to the quick slides and the case presentation.
You are going to educate us about imaging modalities and their present status.
That is that will be the goal today, and these are our supporters and disclosures, no change. This is, as said, 84-year-old female who has a class 4 angina after a small non-STEMI, and also has a positive stress test and had a multi-vessel, cath revealing multi-vessel disease including left main, which Anu can share. This is the ejection fraction, which
so
actually was about 50%, maybe a little better now.
EDP was just about 12, but inferior and infra apex is all dyskinetic, and that's because RCA is total at the ostium, and this is the left main we have. Distal left main, you have both ostial LAD as well as ostial circ that's involved, and rest of the circ is normal. Then we have the LAD here, mid LAD, we would say about 50% or so, and the diagonal is maybe 30% in the caudal view, but this is where we are.
And this actually
distal left main 111.
Right. This LAD looked much more, mid LAD looked after the diagonal or at the peri-diagonal was more tighter. We can go back to our slide presentation.
Before you get into that, the almost normal LV function, does that eliminate the option of the impella here?
Well, that is actually, the question comes that if you need to go to the ventricle, that if you have to support this particular case, which is the EF about 50%, although echo rad actually near normal, but we see it clearly, the apical and infro-apex almost akinetic, if not even slightly dyskinetic. So EF still remain, in my opinion, 50%. So question is, should you use impella in this case? Based on the product approval, I would say it will be hard to press and justify impella use, because this impella has not been tested for this kind of situation where ejection fraction is more than 30 or 35%, as we know in the Protect 2 trial. So in this, and it's not a last remaining vessel, although you can call it, it's a last remaining vessel complex PCI, but what also says the product label that if heart team discussion makes this patient inoperable or high risk surgical risk, it is reasonable to have a left ventricular assist device using impella. So this, with that note, I think if you want to use Impella, there will be nothing against, but clearly in 84-year-old, you always need to worry about giving a bigger sheath size of 13 French may create a more vascular complication. But yes, anytime, any hemodynamic derangement, first thing I would do in this case is a balloon pump, and Impella only in a really, if we, once we go through the process and we see that even little work creates a problem, then maybe we can insert Impella.
And to keep that in mind, we already have access on the left groin.
Right.
We have an
Yeah, we have access on the left groin, and I think this is the point we are trying to make, that more of these cases, some of them are unpredictable, particularly when RCA is closed. So it's okay to have a little sheath in, because then you rapidly, when you do a bailout sheath insertion, may create a problem. We actually had a case last month, and that really urgent or bailout balloon pump insertion, then it was put to, then we upgraded to Impella, really created a problem.
Last question before I have you start the slide presentation. Would you consider even or dare to do this transradial?
Yeah, no, transradial could be done. Actually,
Okay.
these cases with a 7 French, if the artery is reasonable, and here it's if you're planning 2-stent approach, you definitely need a 7 French, or with a DK crush could be done with a 6 French, but 6 and 7 French with a radial is reasonable, although with a female maybe a issue, I don't know.
elderly, yeah,
exact size.
elderly lady, female, I think
Maybe the
if
left
you-
radial.
Maybe left
Then
radial,
maybe
but
left radial.
same. Then you'll have to definitely only do DK crush technique. Same, you'll take probably a longer time to do the same procedure.
Okay.
Okay. All right. So basically, prior history patient also have a CVA besides usual CAD risk factors, including diabetes, but recovered and on good optimal medical therapy. So we have already shown the multi-lesion disease in this particular case with the multi-vessel and left main, with the syntax score is 41 and STS score is 8.2. So why it is important? Because surgeons usually don't take patients with STS of more than 5, because that has been associated with their bad outcome. So this patient particularly had discussion with the heart team, was referred after the cath came out, referred to the surgeons. They declined due to advanced age and high STS score, and patient is with us now for planned high risk PCI of unprotected left main bifurcation, utilizing rotational atherectomy with dedicated 2-stent technique, IVUS guidance and possible LV support. So I think LV support we have already answered that. We'll wait and watch. We have the sheath in, and IVUS we are going to do IVUS, and of course the individual techniques and so. So this particular case is based on the OC latest guideline also on protected left main or complex CAD, that CABG and PCI heart team approach done, and then you have calculation of the STS and syntax score done. These are the one, and that led to, in this particular left main, it will not fit in the left main OC criteria, because this is the case which may appear inappropriate for PCI, but it's absolutely appropriate because CTS declined due to high STS score. So it's a reasonable to proceed with intervention in this particular case. All right, Anno, let's.
So we'll go ahead. We'll IVUS the distal left main, ostial LAD, pull back, as well as the
while presenting it.
mid LAD.
Okay.
But not the circumflex.
I
need.
think it's clear unless
Right.
it's
No need. Absolutely.
and technique wise would be the same. We will go with rotational atherectomy left main to LAD and consider just
Cutting balloon
cutting
to the
balloon to the
ostium of the-
ostium of the circ.
Wonderful. The
Yeah.
renal function is adequate.
Renal, yes, 0.8 creatinine.
Okay.
Now what guide you had, guys? Get me a 3O.
And by valirudin as a
Yeah, good.
direct.
Once you have a long sheath.
Yeah.
Yeah.
7 French, so it was a VL 3.5. We are going with the 3O. So what we'll do, I'll utilize some time. Our goal will be put a 7 French VL, wire the LED, do the IVUS, and then we'll come back and join Anno in this presentation. So as you mentioned, with the Bifurcate app, actually now has gone to like 22 plus 100 people. Has been a very useful. Those who have used it, they are very happy. We have got a lot of input from various users, some suggestions which are being made on this case.
And
No, we have a
upgrade
upgrade.
is coming. Yeah.
An upgrade is coming, absolutely.
No, upgrade is already there,
Yeah.
which has So, they have to download the upgrade now.
Okay. So, as you mentioned, today goal will be the imaging during PCI. So, whether it's IVUS, OCT or physiological testings. So, basically we know that there are numerous tests for ischemia based on the demand, anatomy, pressure and flow. And you can see the center of it, all invasive testing, because they really have shown prognostic parameter, prognostic importance of the FFR, IFR and the CFR, truly showing, but clearly it comes from the non-invasive testing and then goes to the testing on the in our cath lab. And various imaging modalities are enumerated here: FFR, IFR, IVUS, virtual histology, OCT, NIRS, PDPA and some combination of the above. And clinical question always remains is that many times the lesion is ambiguous, and secondly what you need to do in terms of the devices as you change, and lastly that you optimize your results. So, this is where, and of course the mechanism of the stent failure. So, these are all the causes or I would say the clinical question which is answered by this imaging modality. More important, our issue has been that whether imaging modality also improves the outcome, and that will be the data which I will be sharing with you today. So, if we take two basic groups, FFR and IFR, which have been a diagnostic, yes, for the
Rotawire. I was on the rotawire, no?
yeah, no, I was to do regularly. No, regular wire will be easier. Yeah, the wire will bend and so. So, the question will also come whether you use a 2.0 bar or 1.75 bar. So, I think we will decide based on the IVUS and so. So, continue the IFR really has a more diagnostic value, that which case you should do the PCI, because it has shown to the better outcome, we all know. And then of course, it does not tell you whether you need to do rota or so. Post PCI, there are some data to show prognostically that higher FFR of 0.92 above and better, and of course, the side branch closure, whether you should do a PCI or not. The real importance of the anatomical imaging, which is IVUS and OCT, is to show the lesion morphology, and of course, the disease severity, yes, lesion morphology, and then also the device selection of the stent sizing and so forth, and the lastly the safety. The post PCI data of the imaging have shown that it tells you better in terms of position, expansion as dissections, and of course, if patient has a restenosis, that you have the region that why the stent resteno. So, these are the factor overall. And what our goal has been, while IFR and FFR has set into our clinical practice as an imaging parameter to improve the outcome of revascularization as such. That means who should get revascularization or not. So, this is more of a determinant, and if your IFR and FFR are high, you can leave them alone to be called deferred. IFR cutoff is 0.89, FFR cutoff of 0.8. So, this the whole issue really boils down to that what about the IVUS? Can IVUS predict in a randomized trial compared to our regular angiogram? So, are you ready for IVUS now?
Now we are in the mid LED.
Okay. So, before we go on to our 2 points, we can go back to our IVUS now.
This is a mid LED.
Yeah.
It is tight, right? You did a big mark. Okay, there. That definitely, yeah.
This is the one.
I guess we have to take 175 and go all the way to mid LED.
Yeah, and this is the left main, right? Fluoro?
Yeah.
Where is it?
That's left main now. Yes.
Okay.
Yeah. Here, just right. Not that much of calcium here.
Right. This is
right.
what I was thinking. Based on that.
This is the
Oh, bookmark. Okay, done.
Yeah. So, calcium is there at both at the mid LED level as well as the left main level.
Right. Well, left main was a little less, but proximal and ostial LED.
I think 175 is a better, we go
that
all
is
the way
fine.
to mid LED.
175 bar is fine. With the 7 French, you can only go up to a 1.75 anyway. Cannot go with a 2.15, but 2.15 guide, you need a 8 French guide. Cover it now. We'll see.
Okay, can you give us a CSA? Okay. And then ostial, distal left main, ostial LED. Distal left main, keep coming back, all the way back, back. More. Come back. No, this is.
Yeah, this is the left main.
This could be ostial LED also.
2.9. Okay.
That
play.
probably is osteal LAD,
Continue playing.
right? Osteal LAD 2.9. Come back.
So, Samin, mainly when you
Back.
thought of downsizing from 2.0
back.
to 1.75 and considering of course the 7 versus 8 French,
More.
you went
Yeah,
more with your
this is-
gut
this is the
feeling
one.
that you know with
Yeah, this one. This is distal left main.
Right. So no, I mean this is the kind of case I would say probably 2 bar is good enough. I don't think you need to go further because remember the concept
No, but
of these
between
device. Yeah.
between 2.0 and 1.75, what made you?
No, I would say I would have gone if you need to work on the mid LED then 1.75. If you're working only on the left main and osteal LED, 2 bar.
Excellent. Okay.
So basically they actually have opened 1.75 bar because considering that there is mid LED need to be treated, which is appropriate, and then there is nothing downsize issue about that if you need to upgrade in case you could not open the lesion after doing a rotational atherectomy with a 1.75 bar of the distal left main and osteal LED. So that is the key. So there is nothing negative of it. That's the key. So that is perfectly fine, but at the same time you need to be not going gung-ho
Keep it.
that you keep dilating very high pressures and so on and so forth, and you are not done a adequate plaque modification. So right now they are putting the wire, so we can come back to our slides.
For the LED,
so we can
3 of
take care
15.
of it.
And then the question, what do you want for the ostium LAD? If you are doing 175, do you want we take a flextome that will work on both sides?
Yeah,
3.5?
3.25. Yeah.
3.25 flextome.
So therefore, so key is one, we take IVUS and OCT. Now this is the one I showed last year that there was a randomized trial, 7 randomized trial comparing IVUS versus angiography, and these were the trials and multiple patients shown, and one of the largest trial was the XPL, IVUS XPL using 1400 patients for the long stents of the Zions more than 28 millimeter, and basically showed in nutshell the lower MACE, cardiovascular mortality, MI, TLR and stent thrombosis. So randomized trial is shown as you see here, and then of course the p-value for the cardiovascular death is just about 0.05. And then they updated one more trial published in American Heart Journal, same message that IVUS better compared to angiography in all the parameters shown in these 8 trials. So one of the biggest one is I would say IVUS XPL, long stent of the Zions 28 millimeter, 1 year outcome you can see all better in terms of in the IVUS group compared to angiography group or half, although there was no difference in stent thrombosis. So now what has come latest is basically the latest publication of 31 studies combining all IVUS as well as OCT and IVUS and OCT comparison against coronary angiography, and these are the multiple trials. As you can see, the OCT and IVUS are 3, OCT and angiography are 5, but angiography and IVUS are 24, both randomized as well as the major registry data basically shown as shown in one, that truly it is the IVUS which showed lower mortality compared to coronary angiography, and you can see the confidence interval for the OCT is beyond 1. So truly maybe a little statistical trend, but not a real benefit as shown here. And individually, when you compare both IVUS and OCT, clearly that is still continued that IVUS little beneficial over OCT. These are the individual parameter in this main meta-analysis in terms of the MACE, the cardiovascular death, myocardial infarction, TVR and stent thrombosis. So all that really favors more of the IVUS compared to OCT. So why? Because OCT numbers are less, but clearly that what really has shown is the IVUS, because some of the randomized trial have been positive, and this is where randomized versus non-randomized group, randomized in the blue, non-randomized in the red. So clearly the overall data which I showed earlier, they are derived from both of them, observational and randomized, but truly it is more observational which really make a difference in terms of positive IVUS over angio. But overall it seems to be that IVUS has more superiority data compared to OCT versus angio. You can see there many of them crossing the unity, horizontal unity of 1. These are the all 4 meta-analysis group. So the overall the conclusion was that imaging helps, particularly IVUS for stent implantation against angiography. So there is a OCT, again we are using more and more clinically. Still I would say the new kid on the block to have its real impact in our interventional cardiology. Nice review by Ziad Ali on the OCT, and really put into equation exactly what I showed earlier: pre-intervention, lesion preparation, and post-intervention by using OCT. So basically, but you say, well, what has the OCT has shown? One of the trial is the doctor's trial, which showed that OCT does better stent expansion and more patients get FFR of 0.9. So yes, you optimize intervention results by using OCT. Illuminate 3, which compared the OCT, IVUS and angiography, basically was negative trial, showing that primary point of the minimum stent expansion was identical in 3 groups. And of course, there were some parameters of the dissection maloppositions which were a little better with the OCT, but truly the main is the stent expansion was identical between 2 groups, on 3 groups, and actually there was OCT had a 3% complication compared to 1% with the angiography and IVUS. So that has led to a major study, which is the high risk patients, so more complex cases, OCT guided versus angiographic guided with the TVF at 1 year, Illumin 4, which has started, and basically primary endpoint is the minimum stent area after OC in the 2 groups, OCT and IVUS, and even in the OCT and angiography. Even in the angiography, OCT will be done, will be blinded, but more important is the target vessel failure primary endpoint at the 1 year. You say, well, this is a really gutsy, knowing that we don't have any much data to show that OCT was better than angiography, because we have one randomized trial from Japan of 800 patients, OCT versus IVUS guided, and you have identical data. It was published, actually presented last year in Euro PCR, published in JACC Intervention. I did not have the reference here, but has already been published opinion trial. So based on this, we still have to see where we will be based on the Illumin 4, but clearly we need to really put this imaging to the test to show does it improve our outcome, and I am a little skeptical about IVUS data. With the OCT data. So now very nice editorial of this meta-analysis by Dr. Gary Mintz, and basically trying to say that it's the IVUS is kind of elephant in the room, which we say that it's an unnecessarily burden, and he goes through the various 6 points that basically is that the data are not sufficient. We know with the meta-analysis, lack of large scale, we know large trial of IVUS XPL, 1400 patient, then the cost, but cost could be if you have a better outcome, and the safety, we know very low complication with the IVUS, and angiography is sufficient, but not true. But I think the overall puts into it that because of the guidelines. So basically, since there is no guideline class 1 indication for the IVUS, but hopefully these meta-analysis are more important. The IVUS XPL, which is a large randomized trial, may sway and update the guideline. These are the guidelines, are the old one, 2011, still remain 2A and 2B, particularly with the complex cases, and same is the FFR, which is 2A. I think these are ready to be updated and changed. SKY statement has come. Basically, the OCT and IVUS use, you can see here. So clearly, they also have favored IVUS so far, and OCT data are still waiting to really make it to the mainstream and to the guidelines. Okay, with that note, we are ready here to wire has been done, and 1.75 bar is ready to go in.
Go down. Okay. Good. So we have 1.75 bar. We did the direct wire of the left main with the rota side by side. Initially we had the run through where we did the IVUS on the run through.
And then you are back with the rota wire there.
Now we are back with the rota wire, took out the run through.
Samin, several follow-up questions which I'll ask you as we proceed, but
so here would be the same. We will have it just come out of the guide into the left main and do our 3 steps, maybe even in the guide. So there's not much. So step 1.
You're
step
happy
2.
with this guide? It's slightly.
Yeah, I think we are okay. Yeah.
Okay.
Now we will start burring. You see that the burr is in the left main, but that is okay. Come out immediately. Yes.
And
this is
hold
where the
guide.
lesion is.
Yeah.
Slow pecking motion. And this is another indication also, somebody elderly who has a left main disease, totally occluded right coronary artery, we have a pacemaker. So I finished the left main.
And you see the
Come back. Yeah.
patient needed pacemaker.
Pacemaker.
This is when we have changed the flush now. There is no verapamil or nitroglycerin in there, right? So only heparinized flush with the rota glide. We stop putting those vasodilators now.
What led you to do that?
Yeah, it's basically because remember we saw that with the OC, with the orbital atherectomy, they are not using any.
Right.
And knowing with the technique, we said let's try. And last 2-3 months we have done that now.
And it works as good.
Yeah, and has worked out very good.
Okay, come out.
Done.
So we are not doing the circ. I think circ will fly.
Yeah.
Okay, get us the run through and the fielder.
So at this moment, just based on how you use the rotational ablation, you are not going after anything in the mid LAD.
No, mid LAD was
We
done.
did. I did the mid LAD.
Okay.
Yeah,
With
mid
the same
LAD
button.
also has been done. But only question, in my opinion, still remain is that have we done effective little plaque change, not debulking, but modification of the ostial LAD lesion. I think it will be reasonable that we put a wire and put a 3.25 or 3.5 balloon and see whether it expands. If not,
It will expand.
Yeah.
It was not 360-degree arc or not even
Then take a
more
picture.
than 2 quadrants.
Let's see what
Who
the
gives,
angiography.
they give something?
good. You gave atropine? Huh? Why
Wow.
it became tachycardic?
Maybe she has 6 sinus.
Yeah, okay. Yeah, but it looks good. I mean, that's the key. So what you need to do is it has to crack the calcific arc. That is all it has to be done.
This room is breaking too.
Yeah, no, it's not breaking.
Would you be using the angiosculpt, the cutting balloon also for the?
We'll do the flextome now. Yeah.
Okay,
Yeah,
for
flextome,
the-
yes.
For the LAD also, for
Yes.
both, no?
Yeah, both.
So, Samin, going back, very timely review of imaging modalities today, but I almost sensed a little backing off from OCT. Is it because of the
No,
the-
I'll tell you what the reason is. Based on the literature which I now fully aware of, that OCT makes lesion expansion or stent expansion much better. It can detect the dissections, but will it improve the outcome is the issue. Because remember, there are some inherent complication of OCT giving the dye. So that has created some cases actually fibrillation. There was a one live case about 5 years ago by giving that much bolus of dye of 12 cc's. Rare cases may cause even fibrillation. So MACE rate is little higher with the OCT compared to IVUS. That's one. Second, yes, it does a better stent expansion, but that to me, if we say simplistic that all your the restenosis related to stent expansion will be inappropriate. So in my opinion, it takes care of only one part, because we also know too much stent expansion into the media, if you really rupture the interelastic membrane and media, animal data have shown even with the DES having a higher intimal hyperplasia, higher inflammations and restenosis. So alone stent expansion to me is not a predictive factor of restenosis. Yes, it is one of them, but we know that it's not alone. So and then yet I have positive signal of any data to show that OCT has shown benefit. It is very good in terms of imaging the plaque. It's very good during procedure, identifying what equipment you need to use, rota, no rota, and so. But truly the benefit of it is still remain, clinical benefit I would say, is still remain to be proven. That is all. I mean, I may sound a little negative, but based on the data, and we have the classical 800 patient trial, OCT versus angiography. You say, well, it was done in Japan. Well, we did a Illumin 3 here. Again, that was a short trial only, but the key is that this field, it need a lot of work.
Why did you ask that question?
I'll tell you why, because I completely agree with the observations which Samin just made, but it struck me as if the slight lack of enthusiasm comes from the setback from the BVS.
Yeah. Well, BVS basically is that, no, but I would say the OCT probably was the biggest
Driver for
predictor of what happened to the BVS, that they are the one who really then came up with the mechanism,
Right.
that it was the stent scaffold disruption that really created a subsequent thrombosis and so. Yeah, come back in the guide again.
What is going
So
on
see,
with
patient
you?
became very hypotensive
Because
and EK changes.
He's standing there for a long
Yeah,
time.
no, nothing. We just cut. Yeah. Yeah.
Okay, coming up now.
Yeah. So still, yeah. So both these imaging studies based on the. You want to take a picture? Yeah.
Now we are to do the mid LED,
Yeah.
because this may be too big, no, for the mid LED.
Yeah. Mid LED, I think we can do without. Yeah. Done the rota. Yeah. This you
You have to
probably.
pre-dilate, no?
Yeah.
You want to go back here or no?
Yeah.
Here.
Yeah. Yeah.
Because
And
that
then
is,
get to
looks like a
ostals.
5-0,
Yeah. Yeah.
the left main. Now go up and come down immediately.
Yeah.
Yeah,
12.
good, down.
Yeah, see, and then what happened is that we actually have the use of imaging in the ACC DR. They actually don't take it whether you did a IVUS guided PCI or not. They do only for the intermediate lesions. So if for the intermediate lesions at present, about 12% are getting the IVUS to determine whether the lumen cross sectional area less than 4 and getting a PCI. But the FFR is now being done in 34% of cases. The FFR guided PCI, when majority of these patients are stable patients, are the one getting. We know.
Do you have the
FFR
numbers
You have
for
the LED
IFR?
3050?
IFR is not there. That's the biggest problem. That current ACC NCDR system does not have.
Has your use of IFR
Don't you
gone
want
up?
to do the LED first?
Yeah, IFR has not been incorporated, so that coming back to the point, so you do the IFR, while it is okay from the OC criteria for ACC NCDR submission, IFR is not counted. So therefore, the IFR people who are using IFR, I know that a lot of our hospitals in the United States have changed IFR largely because of the simple, straightforward, less cost and so forth, and less side effect. The negative point is that ACC NCDR data still you cannot have IFR into their system yet. So therefore, you can use IFR, but it will not be counted. They are only using FFR so far. But all these things will change, we all know. But at this time, this is a big limitation.
Flextome.
How much is, what percentage of
Down.
cases are you using IVUS in?
IVUS very small. It's
Maybe for instant restenosis,
Yeah.
and of course left main.
Yeah. So I would say about 5%.
Another,
Yeah.
there's a lot, many time that you will not be able to use OCT, osteal lesion.
And if IVUS is 5%, OCT is down to less than 1?
No, OCT just all the investigational. I
Yeah,
mean,
it's
that's
all
the
research.
trial.
Right
What
now,
are the
ours
trial
is
we are using?
all
Yeah.
research. Yeah.
Orbit FFR, Orbit OA, the few trials being done, and then of course use the yellow. So all these trials we have used the OCT, but clinical implication is very rare. That we saw some filling defect in the STEMI patients or something, that then we use OCT, but all for the research tool for the time being.
All right. Is this the flex?
So there are limited use in the sense that if you have a tight lesion where we think the lesion is more than 90%, you go with the OCT catheter. I think we have shown that even in our live case, and when you try to give some dye and there is no dye clearance, you cannot do OCT when the lesion is tight. When the vessel is very large, 4O and large vessel, you will not be able to see anything. When the vessel is too small, 2.5, you won't be able to see with OCT. And same, if you have somebody with the, AKI, renal insufficiency, high creatinine, you would not like to use it.
Totally unrelated questions. I mean, from imaging, I had made a note to ask you this. Are the residual effects of orbita over?
Yeah, I think that has
No, done.
totally has gone. So nobody is even talking about it.
Okay.
Yeah.
Just
So now just to come back to this
you want
point.
to go, this is 325.
Yeah, that's good. We're done.
So there's still a little dent, no?
Where?
Here. See
In
that?
the ostium of
So
the
let's take a
of
picture.
the circ.
Yeah. You want to go to high pressure here?
Yeah, may not open well. Okay, ready?
Yeah. You want to go again?
3.5,
Okay.
because then we can use the same one for
Okay.
later on.
Good.
Looks good enough.
Looks
there.
okay?
Yeah. looks
So
okay.
what should be the stent length and so what should be for the circ?
You put a mid LED stent first, right?
Can we
The
do
AP?
with one stent?
Yeah. We can do one stent. Yeah. Yeah. LED
How?
could be one stent. 3.5.
3.5 LED to left main,
Yeah.
but left main is 5.0, no?
Yeah.
And 4.0 to the circ
Yep.
or 3.5?
And what
Probably
stent
3.5.
would you be using here? The
So
manufacturer.
there's a Promus or Synergy, which one you want to use. In this case, I would say probably Synergy. The senior trial showed compared to bare metal and short depth, 1 versus 6 months, advantage of the Synergy.
Senior patient, anybody who is above
Senior. This is
65 years
super
of
senior.
age
This
will
is
get
super senior patient. Yeah, so you decide. So basically coming back to the
Synergy.
point, I just want to underscore again. The data which I presented for the OCT is does not to discourage people to learn it.
stents?
I think this is the technique of the future which has to just establish in our interventional cardiology. So therefore, like even OCT Atlas has been made by Anu and the team here, which is really getting a lot of momentum, really puts. So everybody should know it. Just same thing like everybody has to know the radial. You don't have to do radial in every case, but you need to know the radial procedure. The same way OCT should know. But what I'm trying to say is that you just need to know what are the limitations. So limitation basically is that you will yet to have a clinically positive data of this device. That's it.
I think I take a little exception to what you just mentioned. I think the challenge is not people in training knowing radial. I think it is the other way around, that
Yeah.
they are not spending enough time knowing even the femoral.
Yes. Yep.
Okay, so now what you want to do? Take a 3.0. First you take a 3.0 16, put in the, I don't think
Yeah,
we
I
should
think to
do
put a separate because the LED should be 4.0 there. Yeah, 3.0. Yeah, good.
No, I don't like synergy.
Yeah.
What there is
Okay, Promus or Promus.
Yeah,
whichever.
Promus.
Yeah.
3.0 16 first.
Yeah.
3.0
3.0.
275.
No, 3.0.
Distal is
3.0.
It's a 3.0 good.
okay, 3.0 16.
And then decide 2 stands for the left main, and
So
we'll come to
3.5
that.
to the
yeah.
circ, right? And put a 4.0 16, 4.0 maybe 16 maybe too long, right?
No, 16 will be okay.
I was thinking possibly the other way around, that you would use a larger stent for the circ and but
No,
they are
Shark-
both good
Shark
good
could be
size
4
vessels.
also. Shark could be 408, 8 or 12. Yeah. Shark could be 408 or 12. Okay. So while we are deciding this, when we come back to the left main
no, let's finish this.
stenting, no. Once
There
we
is
come
a-
to the
No,
left
I
main
cannot-
stenting, I'll be there.
cannot
No,
go
you put
down.
a stent in the LED. Once you're ready for the left main, we'll come back. Okay.
There
Let's
is-
go back to the slides. So now,
There is one question
Yeah.
for you in the meantime. It's from the country, I don't know where. The question is, what is the reimbursement status of IVUS and OCT?
yeah, the majority of them are being approved, and that there is an additional code which you need to put, and there's both physician fee as well as the hospital fee. But only thing is they are reimbursed for the diagnostic procedure or ambulatory procedure. That's the key. So it is not for the inpatient DRG. It's a part of the inpatient DRG. But that's okay. That's many of the procedure we do are part of the inpatient DRG. But yes,
if you are doing
adequately
as
reimbursed now.
no, if you are doing as part of PCI,
Yeah.
is there a extra reimbursement?
Yes, yeah,
Good,
yeah,
good,
both
little bit.
ambulatory as well as only for ambulatory, not for the inpatient. Remember the DRG, not for the inpatient, because there are very few things which
Bet you
changes.
for the
Yeah.
physician it is $29.95.
Well, actually,
That-
physicians.
yeah, I didn't want to say that, but good you said it.
Yeah, no, it's not that low. The physician is about $89,
Okay,
and
so
while
not that
Medicare,
low, please.
yeah, Medicare. No, but it's same. Stent is about 800, 850, and with additional vessel, you have a extra reimbursement. Same thing for the IVUS, additional vessel and OCT, you have a separate reimbursement.
Yeah. See, that's why I wanted 275.
Yeah. Do a distal edge little massage.
Knew that. and then bag is gone, so we have to
No.
balloon it, some little
Yeah.
low pressure.
Yeah.
It's very bad. See that?
Yeah. Plaque shift. This is the
Nothing, plaque
classical
shift.
case of the plaque shift, vertical displacement of the plaque, which is not uncommon.
Give me
And
another
some of
fielder,
them-
let's just,
Yeah, take care of the
this
diagonal
one.
first.
yeah.
Another
Okay, down.
fielder wire. Good.
So now it's become a true bifurcation case.
Yeah. So this is the one where if you haven't gone through the stent struts, you didn't need a kissing balloon. So now you have to go through the stent struts to open the diagonal, then you have to follow in the end as a kissing balloon inflation. So that is what we learned from the Nordic bifurcation 3 trial. So the routinely, which we used to do kissing balloon inflations are not necessary. You want to give verapamil picture or you want to just do it? PCI.
It's already TIMI2 flow.
Yeah. No, but this is the most of the time, and now the basically also what we learned that doing the FFR for this purpose is of limited value, and the same that also we learned from the DK Crush 6. So it is just additional step. So I think it's a rare case when you feel like there's a little haziness and you don't want to do FFR will be reasonable. We don't know anything about the IFR in that situation, but the reasonable to do FFR just to say that yes, FFR is less than
That is
more
a
than
2 or
0.8
12
and you
balloon?
can leave it alone.
I know in the LED it's the run through wire,
Yeah, that's
LED
the
is
run
run
through.
through wire, yes.
and which is this wire you're trying for the
So
diagonal?
now, yeah.
This
so
is
it
a
will be-
diag, will be a fielder now. I mean, leave
There
it
is
alone.
good flow in the diagonal.
Yeah. That's how I was saying that many
You want
times
to go
what
to
you
the
do,
caudal view?
you give a verapamil and get a verapamil. Yeah. Your first view was go to the same, right?
Yeah.
130. Yeah. But let's give the verapamil first. Because the most common cause of decreased flow in the side branch is not the dissection. It's just basically the plaque shift or thrombus protrusion, and that sometimes or vasospasm that gets better by your vasodilators.
How much of verapamil did you use?
I gave 250 mics.
Okay. You prefer verapamil over nitroprusside?
For this purpose, yes. But I mean, could use nitroprusside also. But for the slow flow, definitely the nitroprusside is a better agent. But
I think anything related to the rotablator
Okay,
use
ready?
also is
Yep.
still
yeah,
okay.
no,
Looks
we are
good enough. The
Huh?
flow
Yeah.
is very nice.
No, no,
but
no,
it's
no,
still
no.
there. Yeah, it's still
It'll
there.
go
slow
down.
flow, yeah, yeah. I think let's try to wire it. This is the good view.
Yeah. But
It's a
after
very,
rota,
very large
and
vessel.
just balloon, right?
Yeah.
Should not have happened. You have the 4 already, stents? Oh, no, 12 both. No, other one 16, right? Lady?
Yeah. LED 16 and 12 or 8 actually. The circle will be 8 or 12. Yeah.
12. Oh, short.
You need a balloon support to be able to
No,
at
why
that
it's
level.
not rotating.
Yeah, no, will not be able to rotate unless you have balloon. Because see, in this situation, you are already in the stent, which is a large lumen, and now you try to move your wire will not. So you need to bring the balloon support proximally so that you can torque transmit your torque here. But I think the point is well taken. You see here that clearly.
What was her diastolic when she came in the room?
Yeah, that there is a little decreased flow. See that?
Yeah.
In that, although little haziness and the decreased flow in that diagonal branch.
And it's a large vessel.
Yeah, it's a big vessel, yes.
Now we have something for the LED to kiss.
Yeah. we can get a, in case you need to do a pot, so let's get a 3.5, 8 millimeter high pressure balloon. Yeah,
This is not rotated.
balloon is
at
too far.
all. No, even then, it doesn't matter, far, no far.
Yeah. Or otherwise you use a angulated catheter.
So it's going to the circ. Get me the torquer, I guess. Oh.
Almost seeks to
Yeah. Other question
enter
could be
there.
that you have a very nice loop of your run through wire. You can pull back and see whether that falls into.
Loop is good, but must be the stent strut.
Yeah, it's almost there. It looks as if it's just between the first or the second cells there.
Not
now
here,
the flow
somewhere,
is
no?
even less.
Yeah, this is the one. Let's pose.
You want to take a picture here,
dial
so
it,
you know
yeah,
exactly,
we can do.
or then
We
we have to
already
pot
have that,
otherwise.
yeah. Now do the pot first. You want to take picture? Okay.
It's moving
Take
a
a
lot.
little magnify even.
No, it's way behind.
Yeah.
See?
Okay.
Would a different view help?
No, same view,
Hmm.
magnified.
Yeah, it's a little further down, no? Low region.
No.
What do you have? Send?
Perhaps a new wire. It's
Could be
starting
the 90.
Oh, you want to go with the
Super cross.
whisper?
Okay.
Not, it's nothing to
Then
do
get
with
a whisper,
super cross.
yeah.
Oh, it's actually is making a nice
No, I think we do a pot then first before
Okay.
changing anything.
get up.
Yeah.
Then what you
Put
want?
this one back.
You have a 3.5, no? Or you have a 3.0?
3.5.
No, 3.0.
3.8 here. No, 3.58 is okay. Proximal area. Good. Good. So take
No,
that.
yes, too many
Yeah.
wires. I
Yeah.
mean,
That's okay. That balloon out. Just take
no,
the
leave
balloon
it,
out.
leave it. No.
Yeah.
Then we go on the thing itself.
No, I think you know what? We had to do it on the LED. LED
Means
wire,
with the run through.
run through.
Okay.
Go.
This is a step that we have mentioned in the Bifurcate app, though all the European papers come out, and even in the review article, that pot was a must before you rewire. So you go and try to rewire. If you have difficulty in rewiring, then you do the pot. Pot essentially is that optimizing the proximal area, so that now you'll be able to rewire it. Okay, go up here, right? Or you want to go inside?
No, that's okay.
Not going easy. Wow. Then there is something because of the calcium sticking out.
We worry about the circle later. Let's take care of the LED and diagonal first.
You don't want to wire the circ either?
Okay.
Let's keep the wire
Is
there.
this the same wire?
The circ wire came out when I was trying to get it.
Right.
And we are going to use a whisper wire for the
Yes.
crossing the lesion now.
Like that idea.
Yeah.
Okay, the circ wire is back.
Good.
I think there is some calcium spicule. This balloon is not going easy. Okay, go up.
Almost.
Go up.
It's a 3.58, 16 atmosphere.
And the technique there is you are absolutely optimizing the balloon
proximal.
to be
Proximal.
Yeah.
So
No, no,
if
but
there's any,
within
Don't
the
put it in the
confines
ostium.
of the stent.
no, I'm not in the ostium. They go up. It doesn't matter. Now what can you do? If that's that area that's not expanded, see that?
Okay. 16.
Okay, good. Now let's see if the wire will go.
And
Otherwise
you're
we
using
change
the
to
whisper
whisper.
wire.
No, this is not whisper. We're
Same
still
wire.
on the run through.
Okay. So you're validating whether pot was effective here.
Yes.
All right.
Oh, you know what? The LED wire came out.
Maybe this shape will take you into the diagonal. Almost peaks there. It's shaped almost perfectly for that.
Interesting.
This is the LED wire.
Yeah.
No.
Other wire is out, looks like.
Put the LED wire back in, and then we go with the whisper.
No, you mean take the filter out?
Yeah. Good. And take the balloon out also. It's not going to help right now.
Okay, and then we have to make sure we have the right wire out. Okay, now get us the whisper. So we have the
Throw this
filter in
away.
the circ, we have the run through in the LED. Now we will go with the whisper.
Let's make a nice curve on the whisper. Yeah. Throw this away. 1 second. Throw these all away.
We never tried the fielder again.
No.
Hmm?
Yeah.
We have the 2O balloon ready. Bring the monitor to us.
This little down.
Get this. Somewhere here.
Another question is go to RAO.
Yeah, that's
Same.
what I.
Yeah.
That the origin may be a little more distal to where.
It doesn't matter. We tried everywhere.
Or maybe even more shape.
Shape is gone by the time it reaches the.
Other question is use a super cross, or you want to go to epicranial ones,
Okay,
right?
try.
Yeah.
There we go. No? Yeah. Just needed a suggestion of that view.
Problem is the tip is gone by the time
where?
it.
Yeah.
Call them. Why they have this IVUS board?
Not IVUS. This is the radial board.
Your radial board, yeah. I'm saying
It
radial
keeps
board.
sticking
Why?
all the time.
Why did they put a radial board?
No, that's the way it is. Every patient, it's there lying down all the time. Yeah.
Okay, let me show you the die. Ready?
Get me a fielder. This garbage. Or the same fielder we had.
No, go. Yeah, fielder. Give us the fielder.
Same fielder.
Yeah.
This doesn't even make a turn there. Or you want to take aleocranial? Yeah.
Yeah. This is better.
This is a good view.
Okay, go. is a new one?
It's very tough to say. See that?
Yeah,
It could be above, and I think it could be that we need to end up in getting a supercross here.
No EKG changes.
Yeah.
You look at this view carefully, it looks as if it is starting a little higher.
Way up, high up. Yeah.
Maybe.
You want balloon here now for the support?
Somehow this fielder is not torquing 1 to 1 at all. Okay, give the balloon.
Yeah, that's what I'm saying. It will not, because it will buckle up in the proximal calcium. Now, venture is still not back in the market yet? March, April, okay. So, we have Supercross 90 and 120.
Get me the.
What did you torque?
Somehow this is not rotating.
Yeah, the wire looks to be completely.
No, but the balloon is not going further?
No, I got the balloon down.
Okay. Then straight on the tip. Yep.
See that? Only the run through made some turn there.
This is even directing it.
I can tell you Marvel. Get the Marvel wire. Marvel is the
Not
hydrophilic
Marvel,
wire.
get the fighter.
Huh?
Fighter.
What is fighter? Of which Marvel is of the Boston Scientific.
Yeah, fighter is
hydrophilic
also.
wire.
Fighter.
Yeah. While we were looking for fighter, Marvel is already here.
Tell me, Anu, about both these wires. I'm not so sure many people are familiar with these two, the Marvel and the.
Fighter is hydrophilic tip.
Uh-huh.
I would say it's more of
whisper.
fielder
Whisper.
XT,
Yeah, why do you
but
make-
not
let me try this one.
yeah, not polymer coated. You have the fighter. What else is
I mean,
written
you
there?
have the Marvel wire.
Yeah, because the tip is 0.009.
Yeah.
And,
so the fighter is a thinner tip. Marvel is the.
It's a
good
workhorse
support.
wire. It's a workhorse wire.
Well, workhorse with the tip, although is not the hydrophilic coated, but to me it behave like a combination of fielder and run through. Although it is moving a little bit better.
Is it coated, the fighter tip? Either?
And there was no disease in that diagonal, so that we could not have done anything else except maybe leaving the wire. So just to telling people what we could have done differently in that.
No, even if you leave the wire, you have to recross it.
I mean,
Yeah,
it's,
but
nothing
that
different.
may sometime cause less plaque shift. Little die. Can I see a little bit where it is?
I think you are higher with the. When there,
Okay, now you
it
come out.
almost seems to be originating where the proximal end of the stent is.
Yeah.
Then we'll be in real trouble when we place our second stent.
Just 1 second more. It is touching the wall.
Yeah, we are making progress. Touching the wall. Come
Yeah.
out.
Yeah. All right. So this is gone now. What you are going now? Tell them.
No, fighter, come out.
Yeah, okay.
Could IVUS conceptually help you see where the origin of the
No, OCT can.
OCT could?
Okay. Here. This the maybe it.
Something
Little
it
die now.
turns there, yeah. Right at the almost the origin of the,
No, no, somewhere else.
Yeah.
I don't know, I have a, get a sense it's either there or may even be proximal to it.
Yeah, it means at level of the stent, that where it is coming.
Just about there.
And we have done the optimization at this level. I think let's take one picture. 1 second. Yeah, it is as if they're like.
No, it's
there's a
hanging
flat-
by the
Then,
thread,
yeah,
very, very
even-
high up.
Even
Yeah.
higher than the, where the stent.
Yeah, what about we put a balloon here?
No,
think
no,
it's
no,
going
no,
in the
no,
right
no, no,
direction.
no,
Why?
no, no, no. It's higher up. No, if the fighter also does not
And
go,
we
we
thought
just
the
do the left
challenge
main
in the
stent and
case
come out.
was the ostium
It was
of
the
the
side.
lady and the sir.
Hold it. Give me another, okay, I have one here.
Give the. No, but to before we end up, I think we need to go with the Supercross 90
Okay,
or 120, right? Or 90.
90 may be okay.
90 will be okay.
Now, but let's try this.
Yeah.
Okay, now see that.
What is this?
Yes, yes. I think it's at the proximal edge of the stent. See there? Huh?
Yeah, to me,
You see it? Proximal edge
will-
of the stent.
So this way.
when you run the film, that's the sense it gets, but
Want to put a balloon there now?
Let's see how this behaves, the wire.
and what wire is that?
This is the fighter.
Which is the tip is 0.009?
Yeah, tip is
Hydro-
0.009 and I think it's hydrophilic.
It's touching, just about touching there.
You want to magnify?
No, no, don't.
Whatever it is, you will need a support.
Some dye here now.
Get 90. See? Want to bring the balloon here? No, no.
By the time we bring the balloon, we'll lose it.
Yeah.
Bring the balloon.
Okay, let's get the balloon first.
Get it, 10 o'clock.
We get exchange length fielder wire on this
For the which one?
for the Supercross. Get exchange length fielder. There is there.
I think you have to stent and come out after all this.
No, no, no. But Supercross has to be tried first.
Means even diag, I meant stent it.
Anu, is it possible for you to just keep trying to steer it there even slightly proximal to the stent?
No, that's what we are trying.
'Cause there it seems to be going under
Nothing
the.
is rotating here, see?
I'm just wondering if it would be useful at this moment for a moment to review how it looked prior to this happening, to see where is the origin of the
Origin, we didn't have many views, no, we didn't have aleocranial
True,
because in the caudal looked like it was not involved.
yeah, but
Diagonal.
at least we'll because it may be even proximal to the
I am going proximal here now. In the proximal it is not even rotating.
Pull back.
Okay, no? I think we are going behind the stent strut here.
yeah.
Want to go with the you want to go with the 190, sorry 90 supercross.
Yeah. So they're definitely not behind the stent struts, this one. I think both these things need to come out.
Okay, then we go with the
Another one is that we would need to do a pot with a little bigger balloon even. But I think it will be reasonable to, IVUS will tell us the branches coming in
The origin,
both.
yeah, whether it
that,
is proximal
that
to
in
the
terms
stent.
of the stent, where it is coming from.
Oi,
What happened now?
we have no wire in the LED.
Why? There are two wires. right there.
Okay, yeah, came out.
Yeah,
Okay.
yeah, yeah. They were there. Throw away this wire. Yeah. So now what is the strategy? You want to put up the fielder first and the IVUS, or what you want to do? Or we just go with the
90.
yeah.
But 90 and this many wires will give us trouble.
So circumflex wire you can remove for the time being. That's okay.
Okay. Or do we just take care of the left main?
Although there are no EK changes, but I think we should give one try. Go with this.
Okay, you have the
Yeah, wire is in. Advance the wire.
advance the wire. Did you make a good curve?
Yeah, yeah, yeah. And you don't need much curve there anyway. Good.
Problem
going.
is the fielder never gets into the vessel.
Good. Let's hold it now.
Going.
So, I mean, this is, I have a very,
Want to go a little further?
Why?
Go in inside. Yeah, good. Yeah, turn now. Yeah, I'm sorry, say it again.
I don't
Turn.
know what is responsible for this phenomena. We've been, I mean, 103 odd cases. I constantly monitor the number of people online.
Yeah.
You have any guess how many people are on right now?
No.
We've got 62 people, and
Wow.
at many sites there are
Multiple.
multiple. So this is, I don't know if it is the diagonal phenomena or, I mean, this is a combination of, today we are counting our site,
Sometime.
YouTube and
Yeah.
Facebook. So this is very encouraging. Very,
Okay. You need
and
to-
I urge the people, throw in your thoughts if anybody has any brighter ideas. This is very encouraging.
Should we go with the Gaia?
Yeah, we can go with the Gaia too. But you have to advance this further.
No, 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 it's right there, except that it's a very small hole,
Okay, get a Gaia 2.
or even a miracle.
You
Miracle
tell
3.
Miracle 3.
Get the fighter again, maybe with this it may go.
No.
You know,
Yeah, fight will
this
go, yeah.
particular wire and the combination has made the most encouraging turn there.
But I think you need to go a little further down.
No, no, it says, please look here
yeah,
where
here,
the
play.
vessel is coming up, higher up. Oh.
Yeah. No.
Let me try down. No, I think it's higher up.
Yes.
See, it's not.
Now let's turn, keep it turned there and pull back a little bit. Slightly pull. Yeah.
This is the issue with this. Either you pull or you turn. You can't do both compared to the. Okay, get the Gaia.
Okay. So now we are going with the Gaia 2. So we did the LVEF caudal. You want to go back into the LVEF caudal again? That's where we did earlier, right?
Believe me, view should not make a difference. We've gone to 3 different views.
Yeah. Yeah, that's the only thing.
OCT, no IVUS.
No, IVUS will tell the branch that in the relation to stent. Yeah, you have the branch there. Want to go
Give me
through
a
this?
new one. Anytime I make an extra curve, this thing that doesn't get in.
On the Gaia should not be. Get a new Gaia. Okay, here. This is it.
You want to go to this view? Huh?
Yeah. No, but there is, you can see there.
No, you could.
No, this cannot go.
You want to go this view?
Get a new Gaia.
Huh?
Okay. Which is 50-32. Okay, we are bringing the camera down, screen down.
Okay, that's where we are. Okay, you want to take a cine?
Yeah.
Doesn't help at
Well,
all.
looks good. I would say leave it alone, stent and come
Whatever
out.
the thing we had done has taken away that flap. Yeah. But let's try just put here. Go, go, go. Go right here. Yeah. Pull a little bit. Yeah. Good. Yeah. 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 Yeah.
You-
Good. See?
Without, guys, without even fluoro, we went in.
Okay. Now we are the wire.
Maybe we didn't need this anyway.
Yeah. Okay. Let's do the balloon. No. Now we are tough. Goes in or no? It may not go.
Went in.
Oh, went in. Good. Okay.
Okay.
Now you want to a
change
fielder
it.
or what do you want?
Yeah, fielder, quickly.
Okay. Throw this away.
And what was the wire which crossed there?
No, it's
Sorry?
not fighter. It's the Gaia.
No, but see here, I think it's way before the other.
Yeah. All right. So therefore, the LAO view with the super cross. Good. Go fluoro. Yeah. Yeah. View. One second. And the Gaia 2. And the Gaia. All those things. Good.
It is through the stent, huh?
Now hold other wires now. Yeah. Good.
No?
Yeah. You can
But
hold other wires.
we can only place the wire, next. going on? You have to do it. I
Yeah,
cannot
know,
hold the
but
wire.
You have to have fluoro. Good.
Oh, I see.
Oh, yeah.
How you do?
No, but this has always happened with this 90,
Yeah, yeah.
no matter how we were doing.
Okay.
Want to go back again? Or you will try this without it? Yeah,
Good.
good. Now hold it.
Now the
It is-
what? Go
it is-
straight. Hold it
No,
straight.
hold, yeah.
It has learned the path.
Yeah, now see. So this is always with the super cross when you try, have to be very, very gentle, which we are doing, and then at least it knew the wire had the memory. Okay, now LED wire is coming out.
They don't worry about LED wire.
Yeah, see,
I don't know.
cannot move.
Go straight.
Yeah.
Stay straight.
Out.
Good. Out now.
Good.
Okay, get us that 2O balloon. Let's kiss and finish this case.
Yeah, kiss we can do later. We don't have to worry about because you are going to put a stent in the left main to this LED.
You want to open now this or no?
Which one?
This
The
one.
diagonal, the origin of the diagonal.
Yeah, no, that we had to do. Diagonal origin.
Okay, give me 2O.
Yeah, right here.
This you did not look like.
Or 2.5.
2.5 watt balloon? Okay, yeah, 2O will not do anything,
Yeah,
right?
yeah, but okay, 2.5, 12, high pressure.
High pressure will go? No, it's not going to go.
No, but then go with this, and then we need a 2.5 high pressure or 2.75 high pressure.
Not 2.75. Now don't get crazy, dissect it.
Okay, 2.5.
Yeah.
Yeah. Yeah. 8 will be okay. 8, 12 will be all right. Good.
Samin, what is your agenda over the next few weeks about the interventional transmission to meetings?
Yeah, we actually had 2 of them now, CRT as well as India Live.
Very good.
On one is on February.
I think we should kiss this, otherwise the stent may not go, the
Yeah.
LED stent. Okay, get us you have the 3035 balloon something,
Yeah,
right?
that's same 3.5 balloon. No, we are. Okay.
Yeah, give it
Then give us
quickly.
the 315. Yeah.
Both you are transmitting coronary cases or
Coronary cases, although the India people are asking to do a evolute tower, but problem is that 6 a.m. is a little difficult to arrange everybody.
I never
So-
heard a word difficult in Mount Sinai. In all
Well, I
the
mean
years,
the
Not
terms
us,
of
you need
anesthesia.
other people now.
Yeah,
Coronary we can do,
we have
midnight,
done
2 a.m., 3 a.m.
2 a.m.
But when you have
surgeons and everybody
anesthesia.
else,
Yeah.
I get it.
see that? 1 second, see that now. You think the stent is,
Yeah. Deformed. Yeah. Good. Go.
that's what I meant.
So that pot didn't really do much.
No. The circ wire. Advance the circ wire first. Good. So that's fine. Good. So now I would say that we can bring back the diagonal balloon into the guide. Yeah. Bring the
Cannot go.
diagonal balloon back in the guide.
One thing I'm
Good.
realizing,
Yeah,
this
yeah.
balloon
Yeah.
never does it. You should have had a. You have a new
This the used?
trek balloon.
Yeah, that deep seated guide should do that.
No, that will destroy the stent. Get us a new.
This is you're going to the diagonal, no?
No, this is LED.
LED, okay. And what
NC 325, right?
No,
Or
we just
30.
wanted to do a kissing balloon
Yeah,
inflation,
yeah, yeah.
knowing that the stent otherwise of the left main will not go. Yeah.
Never use a Boston balloons. The emerge balloons are no good. I think a multiple wiring, this thing, that thing, I distorted that stent.
The stent definitely has been distorted.
$62 people are still watching or they're done?
I think it may be more.
Wow.
We can try.
See
to,
how this balloon went?
Yeah.
But that's
good.
a new.
No, but still.
Yeah.
Yeah, I think this step is
Side branch
absolutely
is not
critical
going
here
now.
for this view.
Forget it.
Good. Now it will go.
Okay, good.
Okay. Go.
Now, can we just dilate the LED?
Then do the LED first. Then.
LED to,
Go.
yeah.
Go LED first.
You're going to go
Put our hands
fairly
to the
high
side.
on the LED, no?
Okay. Good.
How high you went? Yeah. Go
18, 20.
pressure.
16.
Okay.
Okay.
Real
I'm
pressure?
18, 20. I'm 20.
You don't need 1820 for
No,
you.
but so we don't have to put another one.
Done.
Yeah, he's 18 already. Good.
Okay, go up here again. This is the ostium of that stent, 18. Okay, now give us the 40, what we had decided? 4016? Down.
Okay.
SS, yeah, it has to be, otherwise we will, right?
Yeah.
Can we make a final decision here, lengthwise?
Yep.
You don't want to leave the diagonal wire now, right?
Yeah.
Okay, some die. Okay, this is, we'll make a decision on the stent length. Go.
Diagonal is good. So nothing need to be done to the diagonal. Wire can come out, and so yeah.
So get us 4016 and a 4012. Agree?
Yeah, we go to the caudal view.
4045.
No, 4, no 4, 5.
No, this is a good. Oh, you want apicaudal?
Yeah, our good. That was a good view. Most of the work which we had done.
So
This-
now the diag wire will come out.
Yeah. So 130. Okay. While you are positioning your wires, let me just complete our
No,
second point.
Please, I have to finish this. We are not talking second point now. Let's finish this case. Okay, give me.
No, put the 12 first. Put the 12 first.
So what is the size you have decided on the?
So we are getting a 4012 to the circ and 4016 to the LED
both 4Os, okay.
Yeah.
and mini crush technique.
Room 2 is working?
They were halfway through. They called and said
Okay.
it's working.
Okay. And it's normal then out. My patient is there,
This
right?
is gave 4012, right?
Good.
You're going to have exactly the overlapping markers.
Yeah. So that with the mini crush, yes. So other point is the DK crush, but you know that require multiple steps, which is okay.
We
too.
already did all those steps
Yeah.
here. For the side.
Yeah.
Pot and Rica. A lot of steps there. Oh. Oh. Is there a recross? Okay, so now I will bring back the circ here, right? Okay.
Yeah.
Ready?
No, the question is you want to bring back the LED stand a little bit more.
I will.
You
I
don't
will.
need that much. Yeah. Good.
Okay, good.
Yeah.
Okay, now
Let's see
ready?
that. Yep. See it to believe it.
Circ has to come back. No?
A little bit, no?
It's okay. Will be all right. Yeah.
I have to bring back the circ. I think we will distort him. Some die, little die. Did I pull the circ? You have the circ?
Yeah.
Are you sure?
This is the circle. This is the circle. Look,
I'm not checking. Okay. Good. Go up then,
going
right?
up. Okay. Circ is stent first.
Good.
16.
down. Now when you go LED, careful, last time she dropped the pressure. Good, down. Now very important, you see that our overlap is barely half a cell in the LED. Samir, you notice that?
Yeah.
Okay, good. Now go up in the LED, up and down quickly.
No, but
now
not
before
yet,
that
not
comes
yet,
out.
not yet.
Okay. This
Take
will
the
come
balloon
out.
out. Yeah. And
Wire out.
Yeah, wire out. Yeah, good.
Now
Now
before
go.
that you normally have to check. Okay,
No.
go up.
You want it here? Go up, go up, go up.
Now for the up
This
and
is
down.
the part which needs to be done quickly.
Down. Up and down quickly. Look, wait.
Let it recover.
Pressure.
Yeah, let it recover.
She has dropped the blood pressure, so you have to wait.
Give
Breathing
one
room.
of neo. Yeah.
With the venous.
Are you
Flush it.
overlapped with the LED stent here?
Yeah.
Yeah, half a cell. That's what I said.
So both of them. Huh?
Sleeping.
What? Yeah. No, but definitely the both LED as well as the left main with the circumflex, just a very little overlap. Yeah. So but this is the
Okay, go up again or no?
Yeah. We have to go up.
Okay. Okay, don't keep too long. Go up quickly.
How
There-
high
Now
are
what
you there
what
now?
size you want? Post
60.
4, 5?
Yeah, 4, 5,
4, 5 you have which balloon?
8 or 12.
For the LED. no?
Circ I
Eight
want
will
a
be
4-0, new 4-0
Yeah.
or 3-5, the same used one.
No, new. Whatever we do, we new one. Yeah, 20 or less, 6. Yeah. Good.
Hemodynamics
So this-
look okay.
So far, yes.
Patient is coughing, so our nurses know cough equal to early signs
Increased
of
EDT.
pulmonary edema,
Increased
so they're
EDT.
giving Lasix.
Huh? What about 8? High pressure, yeah, 8. 8 or 12, yeah.
Now I'm going to recross the circ.
But let's take a picture.
Okay.
Yeah.
Go. Looking good.
Yeah, we always have. Good. So while you're recrossing and once you're ready for final kissing inflation, we'll come back. Let's go to the slides quickly. So we use that time. So basically, the review in Jack talking about all the last year of new technology and particularly physiological with the PDPA. PDPA is basically the IFR through the entire diastole. Remember, the IFR is instantaneous free ratio, wave free ratio during later part of the diastole when there is a little the equilibrium is there. So
Get
and then
some
they
new-
compared with the FFR and CFR. So overall conclusion was that IFR really has a lot of benefit, but again, so 2 trials have shown that, and for 1 year follow up, but we need to go to even further in that way. So we know that FFR is a continuous marker.
Where's
We
the
know
photo?
that at level, if it goes beyond 0.81, it starts having a less benefit compared to medical therapies. So lower the FFR, PCI really is superior to medical therapy has been shown. And then came this new kid on the block last year by the 2 major trials, IFR, which is the instantaneous pressure ratio across stenosis during the wave-free period when resistance is naturally constant and minimal of the cardiac cycle. This is a special proprietary program of the IFR, which is now with the Volcano and Spectranetics. So basically, IFR has, based on these 2 trials, the defined flare and IFR Sweetheart really has shown to be comparable at 1 year. So what will happen subsequently, what happens to the deferred lesion has been the part of the latest, as you can see here, the 2 papers which came out on this field, FFR versus IFR discordance. So basically, yes, it said some cases you do both IFR and FFR. Majority of the cases will be less than 0.8 for the FFR and 0.89 for the IFR, the same lesion. But what if you have one positive, FFR positive, but IFR negative, or IFR positive but FFR negative? So this is actually, you can see that you could have a discordance of both IFR and FFR although majority of them either both
What
are
stent
negative
is
or
a
both
4,
are
5?
positive, as shown here.
8 also?
So basically what it's shown, as you can, and then what they did is
We are ready for
they,
kissing.
they connected with the coronary flow velocity with the hyperemic, and basically came up with a very nice hypothesis, that is that when your both IFR and FFR are low, or your IFR is low but FFR is high, you still have a same connotation compared to your FFR is positive but IFR is negative. And this actually comes out down to this, as you can see, that FFR negative, IFR positive is similar to your FFR and IFR positive. But once you have FFR positive but IFR negative, it is basically means this lesion is not going to give a trouble. We will come back to this. So this basically was the analysis showing that both when there is a discordant of the IFR and FFR, you refer these patients, the 2-year follow-up have a very low event rate. So key is any one of them, but IFR negative is much better in terms of predictive no event at follow-up compared to FFR negative. So this, then another one is the same for the deferred lesion. This basically showed again the plot that of various groups, the FFR positive, FFR negative, and IFR positive, IFR negative, and you can see here high FFR and high IFR both have very low event rate, but identical 2.4% in the deferred lesion. Once you have the low IFR or low FFR, both have a high event rate of 8%. So this is what basically shown in this graph, very nicely depicted, that clearly that both deferred IFR and FFR are okay. And this actually they put into the graph here. So they basically, the conclusion was both FFR and IFR showed significant association with future risk of MACE in deferred lesions. So both are negative, means both are high, it's okay to leave them, and they actually have a good outcome. If any of them is positive, you need to do an intervention, and that actually has been shown. So now they have come a different one. So rather than going with the IFR, what if we go with the entire diastole? So rather than just going to that portion of the IFR which is distal, what about entire diastole, PDPA? And that is where, because that is not proprietary compared to proprietary of the IFR, and this is the contrast study which showed that basically the cutoff was 0.91 of the PDPA, and shown has a good correlation. So all the very early, it has more of a hemodynamic. It is not much in terms of the long-term outcome, but the data are coming that PDPA, and they got approval by the FDA now, just do a PDPA. That basically means that you are checking the gradient across the entire diastole compared to only the distal instantaneous free ratio. So there is some agreement, and actually it is can be applied to more patients. This is same based on the lesion morphology. Another paper in terms of lesion stenosis, combination of PDPA versus IFR as shown here. And the same thing, whether you are high resting PDPA or high IFR are the one which is associated with a very low clinical event. A small number of patients, about 375, but just to say that PDPA could replace the IFR, which is very proprietary in the future, and will be much easier to do, because this will require any different wire. So you have the guide catheter pressure, and then you put any wire which can measure the distal pressure. And then you know, this is basically again the same of the various parameters of the predictive and negative predictive value of the various diastolic phases. This field is exploding. People are trying to come up with some new parameter which will require the least work, basically. Let's put this way. So various diastolic parameters are coming off, but really what is going to show is the comparison has to be the clinical endpoint study comparing these new diastolic measures, even PDPA against IFR, which have been shown. Just to sum up, there is another one which is coming as the quantitative flow ratio, and that is basically the favor that you have the angiogram, and you based on the two view, the special Chinese program developed by the Chinese investigators, that you can tell the FFR just like you do it, take the pacemaker out, the FFR you do during the CT. So this is on the coronary. So many of these cases you can do, and there is a good concordance and nice picture. Actually, when they did the case, live case in China, it was shown there with a very good agreement of the FFR and this quantitative flow reserve done, and good predictive value and so on and so forth. Although there is an article review, the editorial, that approximate truth is not enough until we show the overall benefit, and there is a science behind it, and this is all related to the plaque vulnerability and vasomotion and so on and so forth. So with that note, I'll stop here, and Anu is just going to show where we are before we finish our
Anu, I
last
want
question.
a definite answer, not an approximate truth.
Yeah. Approximate, no approximate, definite truth. Yeah.
Looks wonderful.
All right. So that is it.
So this is
Yeah.
where we
Anu,
are.
great result. The diagonal looks fine.
So we went with the 4O. We had only 8 millimeter balloons. So same recrossed with the fielder without any problem. So we know we have a nice crush because you do see a little dark line there. If you see, I think this is where we saw this.
Yep.
Took out the balloon and everything. Then this is the 4O16 in the LED to
LED.
left main. Recrossed with the
And
fielder.
no, this is very important. Go minus. So the wire comes when you are crossing with the mini crush. You put a wire in the proximal cell. If you are doing with a DK crush, recommendation is you go to the distal part of the crushed stent. So we went very proximal. Go. Sorry. Whole science. This is a big science there.
Big science,
Yeah.
like you can figure it out.
Yeah, of course we can
Proximal or
figure it out.
distal.
Yeah,
And if the same thing with the DAG,
yeah,
it took us 15-20 minutes to get into the side branch.
yeah. Okay, this is now.
Okay, here, so this is 4O and 4.5 in the LED to left main, 18 atmospheres, and then we went back with the 3.5 and did the overlap of the stent between left main to LED. This is the final result now.
Looks outstanding.
Yeah,
Good. And the next one, the last one
Hemodynamically,
looks
the
very good,
patient
yeah.
is doing fine.
very
Yep,
good.
Fantastic. And this
Yeah,
is the one.
this is the final result.
Excellent.
Yes.
Okay, so let's just complete quickly. Two take-home messages: that meta-analysis of all studies comparing IVUS with angiography have shown reduction in mortality and MACE on long-term follow-up. 8 randomized clinical trials in this field also shows trend in favor of IVUS imaging, but not a clear-cut benefit. But yes, trend particularly in terms of mortality, but others, yes. Trials of OCT versus angiography have little or no positive impact of OCT on clinical outcomes yet. I have to add that. The numerous studies have now established the role of IFR guided PCI and its utility in the deferred lesions with high IFR as I shown. Other physiological indices, especially PDPA, are being investigated against IFR, and long-term data are being assembled and to replace, and that will become a very simple testing in the cath lab and no longer proprietary, which is of the IFR. Now, 3 questions very quickly. Following lesion parameters will have features will have the lowest MACE rate at follow-up, low FFR, low IFR, high FFR, high FFR, IFR, and high FFR, low IFR, low FFR, high IFR, and B and D. I have to just change the second one as a high IFR. The second question: both randomized clinical trials and registry data comparing IVUS with angiography during PCI have shown the following: lower mortality, lower MACE, lower TVR, lower stent thrombosis, or all of the above. And the last question: trials of OCT versus angiography to impact PCI outcomes have consistently shown the following: lower mortality, lower stent thrombosis, lower overall MACE, lower target vessel failure, or none of the above. So with that note, we conclude our session number 103, which started a little late, but excellent points of this crossing this complex case shown by Anu, and we conclude the overall presentation now.
I just want to make the points of recrossing, and I think we have made these points even in our bifurcation app, that first thing when you recross, always go for a hydrophilic wire. In this case we saw fielder. If not fielder, next step is we will say the wire that is in the main vessel you pull back because there is already a nice curve. You try that, which we tried with the run through, would not make a turn, and the next step in that situation would be you do a pot. In this particular case, when you have calcium and lot of fibroatherotic disease, you know the proximal part of the stent is probably not well optimized to the vessel wall that is going to the side of the stent. So, you optimize it. Then you recross again with the hydrophilic wire. If your usual hydrophilic wire did not go, then you take the specialty wire which we tried here, which was the fighter, and that time we said now you go with the special catheters which could be either the Venture, or here we use the Supercross which was 90, which is good enough to go to the side branch. Of course, you can go to various views to figure out and exactly understand where the side branches are taking origin from. This is like in this case needed only if you have problem in getting into your side branch, because you seen our usual routine run of the mill crossing the side branch, which is you take your side branch wire, you stent across the main vessel, then you just recross with the same wire worked in the circumflex. So, that is the step that we always say, that is the first thing that you should always try. If you do not, then you go to all this extra step which we have just shown here today.
Anu, excellent case. To me, the summary was modifying your techniques with this evolving case. Very well done. Congratulations to the entire team. We conclude here. Once again, apologies for starting late, and we will see you session number 104 on February the 20th.